Good evening, everyone. My name is Fatima Murad, and on behalf of Atrium Innovations, I welcome you to this evening's webinar on integrated SNP analysis, a crucial component to successful genetic targeting with Dr. Penny Kendall-Reed. Please note that the audio portion of this webinar is now available via voice over IP or teleconference. Please turn your speakers up when joining the webinar, as default audio option is voice over IP. To join via teleconference, please use the phone number and passcode displayed on your screen. Note that the lines will be muted in order to facilitate a smooth flow. Questions will be submitted via the Q&A panel, and this is our only forum for questions this evening. Before passing the call over to Dr. Penny, I would like to encourage you to take advantage of the discount of 15% off all products included in this presentation tonight, valid only for Canadian clients until February 26th. The promo code PKR2020 qualifies for free shipping and can be used one time. The code is displayed on the screen and will also be included in the follow-up email. For U.S. clients, please call the sales department for a special promotion. I would also like to highlight a few aspects of our 2020 education program. Dr. Dixon Tom will present a complimentary 7-session webinar series on UNDA-numbered compounds, patient assessment, evaluation, and practical application starting on Wednesday, February 5th. Dr. Nigel Plummer will be conducting an evening intensive on the integrative effects of probiotics on whole body health, emerging evidence and mechanisms, on the following dates and locations. April 4th, he'll be in Ottawa. April 16th, he'll be in Barrie, Ontario. September 23rd, Calgary, Alberta. Please note that early bird prices apply on all these events if you register now. We are also having a one-day intensive on functional immunology, unraveling inflammatory and autoimmune dysfunction, including new microbiome research. This event is a full-day seminar presented by Dr. Nigel Plummer and Dr. Samuel Yannick. They will be on the following dates and locations: April 18th in Toronto, Ontario, and September 26th in Vancouver, BC. I would now like to take a few moments to introduce you to Dr. Penny Kendall-Reed. Dr. Reed is the director and practicing naturopathic doctor at the Urban Wellness Clinic in Toronto. After graduating from McGill University in neurobiology, she earned a degree in naturopathic medicine from the Canadian College of Naturopathic Medicine, where she received the Dr. Alan Tyler Award for Most Outstanding Clinician. In 2013, she was voted Naturopath of the Year, and in 2018, she was the recipient of the Top Naturopathic Doctor Award in Canada. Dr. Kendall-Reed is the author of 5 national best-selling books and lectures worldwide on genetics and neurometabolic disorders. She's the creator of GeneRx.ca, which is an integrated genetic platform and serves as an international medical consultant for Douglas Laboratories, Pure Encapsulations, and Pure Genomics. Please join me in welcoming Dr. Penny Kendall-Reed.
Thank you so much. Actually, what I'm really excited about of all the things that you just listed is this. I have my own discount code named after me, PKR 2020. That's absolutely fantastic. So 15% off all the products in the presentation. It's a great way to start the evening. I would certainly really like to thank everybody for taking the time to spend it with us tonight. For all of you out in Toronto, I know it is late and you've had a long day at work, and for everybody out on the West Coast, you're just beginning your evening, and thank you for doing that with us. This is my speaker disclosure. Pretty much most of that came in my bio, so I'll let you read that on your own time, but I certainly have nothing else apart from what is in my bio to disclose there. Why the long face? Heredity. You know, one of the first things that we're taught when we get into school is ask your patient about family history. And if they have a family history of cancer or cardiovascular disease, we automatically lump them into a higher risk category. Why? Because of genetics. And we really understand that. We understand that concept of passing down those disease risks. But for some reason, it's taken us so long to understand that same philosophy applies to diet, exercise, how we respond to a virus, what type of inflammatory response occurs in our body, and to what type of insult to the body. Everything comes down to heredity. It is our stage for our health. But the good news is, just because we have a gene doesn't mean that we're going to express it. So it's our job as healthcare practitioners to look at how a patient codes for that gene and increase or decrease the expression of those genes. So that is epigenetics. Epigenetics is really just a field of how our lifestyle, so stress and exercise and diet and medications and pollution, how that increases or decreases the production of the protein that is made through a gene. So what a gene does is makes a protein, and that protein codes for a very specific protein to then do a very specific job. That could be anything from coding for blue eyes to increasing the production of interleukin-6 or making more serotonin. When we increase that production of the protein, we increase the expression of that gene, and then that changes our physicality, or what we call our phenotype. And so these epigenetic changes, how our environment impacts our genes, these are heritable, and these are passed on not just from cell to cell, but from parent to offspring and generation to generation. Epigenetics is really not new. It might be new in terms of our practice, but it actually stems back to 1953 with Dr. Barbara McClintock, who worked on corn plants. And she was theorizing that genes could not only be turned on and off, but they actually changed positions. And the changing of those positions changed the phenotype. And for her work in 1983, she actually won a Nobel Prize. So this really isn't a new topic, just what we're doing with it is new. And this comes down to our nature versus nurture. So our genotype, our DNA, that is our nature. Our phenotype is the expression of our genotype. So again, it's how diet and exercise increases or decreases what that gene does and how that changes our physicality. And one of the biggest variables that changes gene expression is stress. Cortisol actually has the ability to alter over 90% of gene function. It can increase or decrease the expression of it, but we've now actually seen it does even more than that, because cortisol can cross the nuclear membrane, bind to messenger RNA, and actually change DNA transcription. And last year, this was seen in 2 Americans. One was an astronaut and one was not an astronaut, and they were identical twins. And the twin that went up to space for 7 months, 6 months, he came back 7% different DNA than his twin because of cortisol and the impact of stress in space, and that is remarkable. Toxins also have a huge impact on our genes and the expression of them. And when we change the expression of a gene, it's called tagging a gene. There was a really good study done in Mexico, and they looked at mothers who were exposed to low levels of arsenic in their drinking water, and they compared them to mothers who weren't exposed to the arsenic. And then they looked at DNA methylation patterns in the offspring, and they were looking at these patterns in cord blood cells. And then what they wanted to know is, how did this change the growth and the development of their offspring? And what they found was, phenotypically, those that were exposed to the arsenic had much lower birth weights, smaller head circumferences, and lower placenta weight. But then they took a study one step further, and this part really interested me, because then they took the women who were exposed to arsenic, not the control group, and then they compared it with phase 2 detoxification genes. So what they found was women who were variant for one or more of the glutathione, so SNPs, glutathione again being that wonderful nutrient in the body which pulls out toxins, if they were variant, thus they made less glutathione, their offspring had significantly worse symptoms than those who were normal for the glutathione SNPs. So already here we're starting to see a bit of an integration between the epigenetics of toxicity, methylation, and detoxification. So this type of gene tagging is certainly not protective because the arsenic had an adverse effect. But some types can be protective, and this is one with stress. So this was done out of Emory University School of Medicine, and they conditioned male mice to the smell of acetone to a foot shock. So every time they put acetone into their cage, they gave them a foot shock underneath, and the mice would shudder. And once this conditioning had taken place, just like with Pavlov's dog, they found that the mice would physically shudder when they were exposed to the smell alone, so they didn't have the foot shock underneath. But what they also found was that they developed many more M71 receptors. These are the smell receptors that are able to detect acetone or acetone and at much lower levels. So this is a protective gene tagging. What these mice started to do was upgrade or increase the expression of the genes that coded for these receptors, increasing the number of receptors so that the mice could learn to smell acetone at much lower levels or from further away. What was also remarkable, though, 2 generations later, their mice had never been exposed to acetone, never been exposed to electric shock, but as soon as they put acetone into their cage, those same mice would shudder just as if they had an electric shock. And those offspring also had increased M71 receptors in their brain, showing an epigenetic marker or a tag on that gene. So this is remarkable. Again, no exposure to it, and this is passed down through generation after generation. And finally, a really great study out of New York's Mount Sinai Hospital. Researchers looked at a group of Jewish men and women who were interned in concentration camps during the Holocaust, and they compared them to a control group who lived outside of Europe during the war. And they also analyzed the genes of 2 generations of both sets of groups. And what they found was that all descendants born to the Holocaust survivors had really high levels of anxiety and stress. This was both self-reported and diagnosed, whereas the control group, they didn't see any increased levels. Really important, though, epigenetic tags were found on all the genes associated with trauma. So everything from inflammation to inability to sleep to panic, anxiety, worry, and it was only seen in the Holocaust survivors and their offsprings, not in their children. So when we start thinking about our own environment, we have to not just think about our body, we have to think about our children's body and our grandchildren's body and everything that we are passing on from generation to generation. When treating ourselves, we also have to look back to our grandfathers and their grandfathers and see what was going on. Whenever we look at gene interaction and how cortisol or how an epigenetic change takes place, we've been looking at how it increases or decreases the expression. But as I mentioned before, cortisol is one of the biggest variables that alters gene expression. And Ohio State Medical University, they actually found when they looked at 170 genes, stress turned 100 of them completely off. Not just decreased them a little bit, but turned them completely off. And it never turns off the good ones of let me sleep better or help me lose more weight or be more calm. It's always the bad ones. So again, they decrease their wound healing, they increase their inflammation, they decrease sleep performance, increased weight gain, poor cardiac control. But the good news is we can change that. And a really quick study on, it was only 8 weeks where participants did some meditation and yoga. At the end of the 8 weeks, those who were novice in meditation, they changed over 1,500 genes, upregulating 874 for health and downregulating 687 for stress. That's remarkable in 8 weeks with just meditation and yoga. The experienced meditators, they altered over 2,200 genes, again, improving most of the health and body's responses to physical stressors. So just in case you're new to genes, I'm going to do a really quick review. When I talk about increasing or decreasing a gene, what are we talking about? We're talking about a SNP, a single nucleotide polymorphism. So when a cell wants to make a copy of itself, it copies itself completely, then divides in 2, and it gets an exact replica. But if a mistake occurs during this, like a typo, and one of those 4 base nucleotides, those A, G, C's, or T's, gets swapped out for a different one, then a different gene or a different SNP is created. And that means that a different protein is then produced from this gene because those 4 base nucleotides or that gene is that recipe for that protein. So this is what it would look like. We see 3 G's G, G, and C across the top. On the bottom, we see G, A, and C. So the G and C were swapped out. We now have a new recipe for a protein. Therefore, that gene is going to function in a different manner. So what happens when this occurs? Sometimes absolutely nothing. It depends on what gene it's at. Because if we look at our entire genome, we actually only use, that we know of, clinically relevant genes, 1.2% of those genes. That's it. The rest of the genome right now, we don't know about. We don't know what it does, or we call them nonsense genes. So if this occurs at one of those nonsense genes, nothing happens. Or if it occurs at, say, a gene for eye color, your eyes might not be quite as blue, or they might be even bluer. But if it does occur at certain genes which do affect our health, it can be really profoundly effective. It can do anything from the increase in the progression of a disease, how our food is absorbed, how we respond to exercise, how a drug works in us, what is our immune response, our inflammatory levels. It could change anything or nothing. So again, our job is to look at that gene. How does the patient code for it? If it's a really good coding, let's keep it turned on. If it's not so good of a coding, let's turn that off. We also have to remember that genetics is just one piece of the puzzle. So just because we have that gene doesn't mean that we're going to express it. So what we need to do is I see this so many times with docs, so they'll get a report back, or a patient will come in and they've got a report back and they see all these reds or all these bad genes. But that patient is really healthy and they're not expressing those genes because they may have kept their lifestyle in a really great place, so they've kept that gene turned off. So always marry the genetic result with the patient sitting down in front of you, as well as with our physical examination, family history, personal history, and all of our lab work. So is this really important? Do they really work? Absolutely. Genetics actually accounts for 40 to 70% of variation in body weight, and it accounts for 50 to 60% of individual variability when it comes to athletic and physical performance. Some diseases like Huntington's or cystic fibrosis, completely genetic. But most of the onset disease lies in the middle. It lies with a combination of a genetic predisposition and those lifestyle variables that we promote the expression of the gene. And that's what we're really talking about. So why do we test this? Well, we have a patient with a family history or personal health history. They may have a parent who has a cancer gene, but they may not have inherited it. Don't you want to know that? Some pathways too, things like methylation, detoxification, you can't guess that. There is no lab work for that. There's small little ones that we can guess, but we're not going to get an accurate result. We also have a lot of wonderful labs that we use routinely, but there's a lot of inaccuracies in those, and we're going to go through those. And then what we've all had, that patient who is not responding to what they should be responding to. We put two patients who look like they have the same ailment going on the same protocols. One responds really well, one doesn't. Why? Genetics. So when we talk about variations in hormones, why can't we just use this anymore? And I'm going to use thyroid as a really good example here. There's a mean increase from day to night in TSH by 140%. It fluctuates throughout the day. So if a patient goes in and does their TSH levels at 8 in the morning and at 11 in the morning, they're entirely different. Estrogen also increases thyroxine binding globulin, so it deactivates T3, increases TSH, and therefore falsely increases T4. This is more significant if they're on birth control or mid-cycle. So now what if we have a patient and we're testing their thyroid levels frequently, and they go in on day 1 of the cycle and day 14 of the cycle at 8 in the morning and at 11 in the morning. And then let's add in the time of year, because TSH naturally increases in colder months, and it decreases in the warmer months. And then we have to throw stress in here as well, because the hypothalamic pituitary adrenal stimulation also falsely increases TSH and increases those peroxidases and antibodies, so it doesn't give us a true thyroid picture. And we can't completely look at the cortisol, 4-point cortisol test, because it doesn't show us the most important time, which is 2 to 4 in the morning. And when we get a flat line in the morning, it's frequently because there's a peak at 2 to 4, and then that is the hypoadrenal picture. Estrogen itself also fluctuates. It actually fluctuates 4 times throughout the day and almost by 50% in one of them. So we look at all of these variables, and although our labs are wonderful and we want to marry our genetic results with them, we can't rely just on our blood and saliva lab testing. When we're looking at hormones in particular, we're looking at unconjugated hormones. Unconjugated, again, these are the free-flowing hormones in the blood. It is not what is bound into the receptor. So does somebody have a lot of estrogen in their blood, or serotonin we could say here, or even B12, let's say, because they have very few serotonin or estrogen or B12 receptors with which to bind it. Therefore, they actually are clinically low in estrogen or low in serotonin or low in B12 symptomatically, but yet their blood levels look fantastic because there's nowhere else for that hormone or vitamin to bind to. So we have to look at the genetics here. So what genetics is going to tell us is the whole metabolic pathway of each hormone and of each vitamin. How much starting hormone do we make? How do we convert it into its active or inactive form? How do we clear out that hormone? So it's giving us what's bound and what's free. It's not just a static test. We get the entire metabolism of that hormone. So let's take a look at how this would work in our practice. Let's take a look at that unresponsive patient. So we have a patient who's eating really well, but they continue to gain weight. Their diet consists of moderate organic proteins and high healthy fat intakes, few simple carbs, minimal alcohol, and a ton of vegetables. Looks great. But because they're continuing to gain weight, they tried the ketogenic diet because that's what everybody does these days. They lost weight at first, just as everybody does, because if you cut out sugar, you are going to lose weight. But then they slowly start to gain it back and slowly get an inflammatory response. So why might this happen? MC4R, this is a gene which talks about satiety versus hunger. It's ghrelin versus leptin, which both deal with our metabolic rate and our emotional ties to food and how we think about food and how hungry we are. If you are heterozygote, so you just have even one C allele, there is an 8% increase in obesity, independent of diet and exercise. If you are variant, meaning 2 C alleles, you increase your weight by 43%. These are the morbidly obese patients. These are the childhood obese children. These are the patients who walk in and they're like, I'm not eating that much. It's because of this. You cannot change this through diet and exercise. We need to change adiponectin, leptin, and ghrelin, those 3 hormones. Which leads us into our next gene, adipaq. This is a gene which codes for the production of adiponectin. That is that hormone which controls blood sugar levels, insulin levels, fatty acid oxidation. And when you have a variant allele here, even one A allele mutation is greatly going to slow that metabolic rate. Then we look at ApoA2. This is a gene which talks about how our body handles saturated fats. And if you have a variant allele, which is C on 23andMe or A in clinical research, one is using the reverse strand. These mutations will increase ghrelin production, so make us actually more hungry and increase adipogenesis when consuming more than 22 grams of saturated fat per day. The FTO, this is one of our largest metabolic genes, and FTO codes or deals with leptin, ghrelin, and adiponectin. It deals with hunger, food cravings, fat storage, and ironically, when you have an A allele, all of those variables are downgraded, but you increase food cravings for both fats and sweets, and those are the very same foods that turn on the expression of this gene. So just to show you how important this gene is, as well as how important we cannot cookie cutter a diet for anybody, this is a picture of 2 mice. The one on the right is the normal allele. So this is the TT mouse. The one on the left is the variant, that's the AA mouse. Both these mice are 20 weeks old. They've had the same diet, the same exercise, and the same sleep patterns, and look at the difference in size. If this doesn't right here show you that you can't just go into chapters and pull a dietary book. I've written many dietary books. I don't even carry them anymore because you cannot cookie cutter a dietary program. It has to go by your genetics. So how is genetics going to change the treatment for this person who ate a clean diet before, tried keto, gained even more weight? This patient, because of the MC4R, the FTO, and the ApoA2, they require a really low saturated fat diet. They need to be below that 22 grams per day. They also require low simple carbohydrates because of their FTO gene and a higher protein diet. Ideally, they should do intermittent fasting because when we fast for longer than 8 hours, we start to increase the production of adiponectin through our bone marrow, and that will also help to boost our metabolic rate. Keto is entirely the opposite thing that this person should do because of her genetics. It's going to increase cholesterol, inflammation, and weight. Because of the MC4R gene there, we also have to target those genes, otherwise they're not going to turn off. And here we can use trimetabolic control, or TMC. This is by Douglas Labs, and this has dolichos biflorus, which we'll see piperbetyl, and acetyl-L-carnitine, which regulates both ghrelin and leptin. This is ideally taken 2 capsules 30 minutes before meals, 3 times daily. So this is what the TMC looks like. The dolichos biflorus and the piperbetyl, they have been shown to increase leptin, regulate leptin, increase adiponectin by 18%, and drop ghrelin by 20%. That is a huge impact on the body. So now what we're really interested in here as well is the integration of genes. So when we look at a lot of reports, they'll give us just one gene for carbohydrates or just one gene for fats. And so if by chance a report is giving you all 3 genes that deal with carbohydrates, such as these 3 here, we want to know what they're going to say. So TCF7L2, if you get a report and it says you're variant or you're red, that means you don't respond well to carbohydrates, so you need to restrict them. The next gene they may give you, IRS1, you're normal for that one, or you're green. So you do respond well. You don't need to worry about restricting them. GIPR, you're heterozygote, or you're yellow. So you respond less well to them, so you need to moderate your carbs. Well, what does that mean? Do I eat them? Do I not eat them? What does respond well mean? We want a full report, a full idea of what's going on. So let's take those exact same genes with the exact same codings. TCF7L2, if you are variant, this means you are very sensitive to carbohydrates. You produce more insulin than the average individual when you eat carbs. It greatly impacts your blood sugar levels and your weight. It increases feeding behavior towards carbohydrates, and that impairs beta cell function. This is the #1 diabetic gene. IRS1, you're normal for this one. This means that your cellular growth and differentiation patterns through the P13K and IGF-1 pathways are not augmented when you eat carbohydrates. These pathways are the cancerous pathways, and these get turned on by carbohydrates when you're heterozygote or variant. GIPR, this is a gene which talks about the production of inflammation in the GI tract through carbohydrates. And here, heterozygote, you do it a little bit, as well as increasing insulin levels. So we now know that somebody's sensitive from an insulin and a beta cell point of view, not sensitive from a cancerous point of view, and a little bit sensitive to inflammation in the GI tract. So what do we do with that? Putting all of this together, they need to keep the type of carbohydrates that stimulate those genes, those are the grains, the starches, the fruits, and the alcohol, to a maximum of 2 meals per day, where the physical size of that carbohydrate is half the physical size of the protein. We can also use metabolic extra by pure encapsulations to help stabilize blood sugar levels and insulin regulation. And then if they do need to support some inflammation in the GI tract, we're going to throw some glutamine in there to support and rebuild up that lining. So metabolic extra, this has the chromium, the alpha-lipoic acid, it has resveratrol, it has berberine, all which will help to stabilize those blood sugar levels. And the glutamine that we know that protects the mucosal lining, it ensures proper nutrient absorption, and it also helps to regulate out immune cell proliferation and cytokine activity in the GI tract. So let's take a look at exercise and how we can integrate genes here. There's a lot of different types of genes, and again, a lot of reports will give you just 1 or 2. So a really popular one is called actin-3. Actin-3 is a gene which codes for the production of alpha-actin-3, which is a protein which makes fast-twitch fibers, so sprinting fibers. If you're a CC, that means you're normal, so you have a lot of fast-twitch muscle fibers. You're ideal for sprinting. CCs also have a really thick myelin sheath, so they have a faster messaging system from their brain to the muscle that says, go, sprint, because that's what we want when we're sprinting. So from this gene alone, this person is definitely catered towards sprinting. But now let's take a look at what happens to the blood perfusion when they're exercising. So this is an ACE gene, an angiotensin-converting enzyme gene, and it talks about vasodilation or constriction. The AA is considered the variant position, and that means they actually don't tighten up or constrict the blood vessels well. They have a more dilated, slower blood flow across the muscle bed when they're exercising, a poor electrolyte control. So these people are designed for longer, slower endurance. These are actually the marathon runners. And if they try to sprint, they're going to increase their inflammation and increase their creatine kinase. And then if we look at their ADRA-B2, this talks about bronchodilation and oxygen perfusion to the muscles when you're exercising. Here again, they're variant, which means they have decreased bronchodilation. Again, it's a slower delivery of oxygen for this position for a longer period of time. What is that again? That's endurance. So we've got some contradictory things here. We have the muscle fiber, which is designed to sprint, but the blood flow and the oxygenation is designed for endurance. So which one do we tell our patients to do? Well, we have to put them all together. So how this changes it, we need to moderate the intensity of the workout. So they can still perform sprints, but they need to be longer, slower sprints. Rather than that traditional 30-second sprint at a 95% capacity and a 10% recovery at almost a stop, we need to do about 1 to 2 minutes at around 75% capacity and a longer, faster recovery, so 45-second recovery at about a 50% capacity. They need to perform these workouts for a longer period of time, too. Traditional HIIT is 30 minutes. This needs to be 45 minutes to an hour. If we need to help support the muscles, again, because we've got the slow twitch, we can use glutamine, once again, because that's going to help repair the muscles. And as we saw through that ACE gene, there's a bit of a poor sodium-potassium control, so the big thing we need to do is increase the potassium here. And using Genestra's potassium is one of my favorites here because it's a 250 milligram and a great absorption with it. So let's look at the stress response. A lot of programs out there are only looking at how much stress hormone we make through the adrenals and how we clear it out. They're very important genes, but there's more than just that. So let's look at what happens here. We have the ADRA2A gene. This is a gene which talks about how much glucocorticoids you produce for each stressor. So GG, this is the normal response. Each time this person is stressed, they make the normal amount of stress hormone. But then we look at NR3C2, and this looks at mineralocorticoid receptors, which also bind glucocorticoids, on the hypothalamus and the pituitary. So this is how we stop that negative feedback. So when we have a stressor and that stressor is over, we know that cortisol is supposed to bind into the receptors in the hypothalamus and the pituitary, and that's how we stop stimulation down the HPA axis. Well, with the NR3C2 being variant, they have very few receptors to stop that. So once a stressor starts, they just keep stimulating that HPA axis over and over and over again. FKBP5, these are receptors solely on the hypothalamus for cortisol. And again, they're heterozygote, so they have fewer receptors, once again, stimulating that pathway. So we see a lot of increased anxiety and depression and PTSD in both of those two codings. Then we also have CRHR1. This is a gene which codes for the CRH receptors. And here, this time being normal is disadvantageous because that means we have more receptors. But CRH receptors are not receptors that turn off the HPA axis. They actually stimulate it. So now we have more stimulation down the stress pathway, again decreasing the ability to move from sympathetic into parasympathetic. And finally, we have the COMP gene. So this is how quickly we clear out those catecholamines or the cortisol, adrenaline, and noradrenaline. And here the example is heterozygote. So they do it at sort of a slightly slower rate. The normal coding would clear them out at a very high rate. So let's put all this together. Again, most platforms only consider the adrenal response and how it clears it. So if we looked at just that, their ADRA gene, normal amount of catecholamine production. We look at their COMT, average clearing. So we'd like it to clear a little bit more, but that type of treatment, we could easily treat that with lifestyle modification. We could do some meditation, we could do some deep breathing, get some consistent patterns, and that would give us that Zen look with this. But what happens if we throw in those other genes? So now we see that we have the pituitary and the hypothalamic receptors are variant and heterozygote, and we have increased CRCH. You cannot deep breathe your way out of this one. We need to reset those receptors on the hypothalamus and the pituitary. We need to shut off that HPA stimulation. So we require that Serotonin Plus in order to do this. So again, we have that casein tryptic decapeptide, which actually resets, the only thing that we know that resets those hypothalamic and pituitary receptors, turns off the HPA axis, and gets them back into parasympathetic side. And this is what's going to give us that calm, stress-free feeling. To relieve stress, I do yoga. Just kidding, I drink wine in my yoga pants. That's what we're going to get if we don't start resetting this HPA axis and looking at all of these genes together. So let's take a look at estrogen metabolism and how this affects it and why we need to integrate these genes again. So CYP17A1, this is the phase 1 enzyme, and what it does is it increases it tells us how much starting estrogen we have, basically. Then we have CYP1A1. This is taking that starting estrogen. How much of it do we convert into 2-hydroxy, the anti-cancer form of estrogen? Then we have CYP1B1. That's that phase 1 enzyme again. How much of this starting estrogen do we push into 4-hydroxy, the cancerous form of estrogen? Then we have CYP3A4. This is a phase 1 enzyme, but it helps to actually break down estrogen, birth control, and HRT. And then we have both COMT and GSTP1, GSTP1 being a glutathione gene. Both of these are phase 2 enzymes, and these both bind out and clear out estrogen. So let's take a look at a couple different scenarios with this. So scenario 1, your variant for CYP17A1. That means you start with some increased estrogen. And then, but we look at it, and through your CYP1A1, you push a good amount of it to the 2-hydroxy. And through your 1B1, you don't really push much of it to the 4-hydroxy. So that's a really good estrogen profile there. Through your COMT and your GSTP1, normal again, so you have a really good clearance of this. So any estrogen we give this person, whether it's herbal, whether it's bioidentical, whether it's traditional HRT, whether it's from the environment, pesticides on our food, and endogenous estrogen, this person will push most of it to the good form of estrogen. These are the people that you see are positive for the BRCA gene but don't get cancer, because they push everything to the right form of estrogen and clear things up. So if this was a patient of mine and they were suffering from hot flashes and they needed HRT of some form, I would have no issues with it. I have real issues with people giving any form of HRT and not testing the genetics for this exact reason. The pills will put a stop to your hot flashes, Mrs. Bates, but maybe we should reduce the dose. You'll also find that when people are normal for this, because they're clearing things out quickly, you can also quickly get them off of their HRT. But let's look at the other end of it. What if they code differently? So CYP17A1, they're normal this time, so we have decreased estrogen, starting estrogen. So we think, oh, that must be good. But they're variant for the 1A1, so they don't push much of it to the 2-hydroxy form. And they're variant for the 1B1. They push a lot of it to the 4-hydroxy form. That's not a good picture. Their COMT and their GSTP1 variant, they don't clear it very well. I am not putting this person anywhere near HRT, bioidenticals, and most herbals. What this person needs is the DIM and detox. They need glutathione, and they need NAC. The DIM and detox, DIM is a fantastic product or ingredient, as we know, which converts the 4-hydroxy into 2 and helps clear out the 4. It also has some NAC in here as well, which will be that phase 2 conjugator to bind out the estrogen. Glutathione, one of my favorites, as I'm sure it is for you, as a major phase 2 scavenger to pull out and bind out estrogen and many toxins. We always want to give glutathione with NAC. Because if we don't, what will happen, we know that NAC is the precursor to glutathione, but if we don't have enough NAC in the body, then we will actually break apart the glutathione to get NAC, and that will be used elsewhere in the body, so we render that glutathione useless. So we definitely want to give these together. And we can also increase broccoli, because we know that's where the DIM comes from. So encouraging either 3/4 of a head of broccoli a day or 2 tablespoons of broccoli sprouts is the equivalent to 1 capsule of DIM. So how does this affect our hormones? Let's take a look at dopamine. So scenario 1, DRD2 and ANKK1. These first 2 genes talk about the production of dopamine and how many dopamine receptors we have. So through the DRD2 gene, the first one, they're heterozygote. So a little less than the normal amount of dopamine receptor activity, but it's not too bad. And through their ANK1, they're normal. So they have a good amount of dopamine receptor production and activity. But their COMT is fast, so COMT also clears out dopamine as well as we saw, the adrenaline and noradrenaline. They're normal, so they have a fast clearing of that dopamine. And MAOA, the monoxamine gene, also clears out dopamine. So here they're normal and they're fast again. So this is actually a person who's a really good candidate for dopamine because they have a lot of potential receptors to bind dopamine, but they're clearing it out too quickly. So that if we give it to them, it's not just going to hang out in the blood and create some problems. It's going to go up into that bevy of receptors that are there. And this is particularly true under stress because under stress that will decrease the production of the dopamine. So here we want to use the Focus Plus, or we can just use the straight tyrosine capsules. So the Focus Plus, here we're going to have that tyrosine in it, but we also have the mucuna, we also have rhodiola, we also have L-DOPA. So we have everything that we need to increase the production of dopamine. Or we can just use the straight tyrosine here, that precursor to dopamine. This is great too if somebody is a little bit more stressed because if you have the Focus Plus with the rhodiola in it, it can actually crash the COMT gene. And if we crash the COMT gene, that means we slow it, which yes, that means you do get increased dopamine, but it also means you get increased adrenaline and noradrenaline. So in that case, I like to go to just the tyrosine. So let's take a look at the next integration of dopamine and why genes are so important to know before we start treatment. DRD2 here, heterozygote again, so average amount of dopamine receptor production. This time though, their ANK1 is variant, so they have very few receptors here and dopamine activity. They're also variant for their clearance through both COMT and MAO. So their low dopamine signs may be coming not because of the low dopamine per se, but because they actually have very few receptors. Because they clear it out pretty slowly, so there should be a fair amount in their blood all the time. It's just that they have such low receptors. So this person most likely does not need dopamine treatment. They might need some stress treatment because, again, cortisol blocks that production of dopamine, and we would know that from their stress genes. But if we put them on a whole bunch of dopamine, what we risk doing, because there's not enough receptors, particularly in the prefrontal cortex, because that's really where those DRD2 ones are, receptors for focus and concentration, we risk pushing that dopamine to the anterior striatum, and that's where we get that really big emotional response. So rather than helping them focus in, we've actually made things worse. And this is one of those places where I definitely wouldn't use a Focus Plus, or I wouldn't use the rhodiola here. I love rhodiola for many different things, but if you don't have enough receptors for this and you crash that COMT gene with the rhodiola, it's going to increase an adverse dopamine effect. Let's look at the same scenario with serotonin. So first scenario, 5-HTT-LPR. This is a gene which talks about how we reuptake serotonin and how we transport it. And when they're variant, there's a really low uptake into that receptor and a really low transportation. We look at TPH2. This is the production of serotonin in the brain. They're normal. They're actually pretty good with that. And MAOA, this is the clearance of serotonin. As we saw, it also clears dopamine. They have a normal production here. So they clear it quite quickly. So they make a good amount and they clear it pretty well, but they don't uptake it very well. So we need to help keep pushing the levels a little bit higher so that, but more so throughout the day. And this is the key part. Because they don't have as many, they don't transport it as well, we need to give them a little dose all throughout the day rather than a big dose at once. Because if we do a big dose at once, we're going to throw them into serotonin syndrome because there's not enough receptors and transportation there. So we give a little bit throughout the day, it transports it slowly, uptakes it, and that wears out, transport it slowly again, uptake it, and wears it out. So the timing of the supplements is also determined by our genes. And SeroPlus, again, is one of my favorite products for this one because not only do we have the 5-HTP, the precursor to it, but we also have all of the cofactors to then take that 5-HTP and push it through, as well as the methylation factors into serotonin production. So let's look at second scenario with this. So this time, the 5-HTT-LPR is normal. So we have a really good uptake and a really good transportation. We have an average, so a slightly lower serotonin production through TPH2, and we have an average clearance, slightly lower clearance. This is not a good candidate for serotonin because this is a person who we're going to easily throw into serotonin syndrome because they're already taking it up and maximally transporting that little bit that they have. So if you put too much in the blood, it's going to overload the body and throw them into serotonin syndrome. So as we can see, genetics, one piece of the puzzle, but a really important piece of the puzzle. It's going to really help to determine what supplement we use, how is our dosing, what types of foods we use, when do we eat them, and how much. So let's put this together then into case studies. So this is a 32-year-old female with breast cancer. She came to me after she had grown tumors 5 separate times in a 3-year period. And the last time was in her skeletal muscle, places that we just should not be growing estrogen tumors. She'd undergone her maximum doses of chemo and rads. She was a non-smoker. She had a really balanced organic diet and exercised regularly. She was one of those people you look at and you're like, oh my God, why? Really strong family history of breast cancer, but every single member was negative for both BRCA1 and 2 genes. So on her genotyping, some of the things that we pulled out, CYP17A1, heterozygote, she was a little bit more starting estrogen. She's variant for 1A1. She pushed nothing or very little to the 2-hydroxy. Her 1B1 was variant. She was pushing very little into the pushing a lot into the 4-hydroxy position. Her clearance through her COMT and her GSTP1, both variant. So she couldn't get rid of estrogen, but she also couldn't get rid of xenobiotics. So when there's GST SNPs as well, and we can't also clear out a lot of the toxins in our body, or if we have SNPs at the cytokine genes like IL-6 or TNF-alpha, that increases the inflammatory load on the body, which then inflammation like cortisol starts to trigger off a lot of these other genes as well. Her NQ01 was GA. This is a gene which it deals with all NRF2 pathways, so all glutathione pathways and phase 2 pathways, but it also talks about how they respond to most of the chemo drugs for estrogen receptor cancers, and she was not responsive to them, which shows why she was still growing so many cancers. So what did we do with her? We did glutathione, a capsule twice a day. We did NAC, a capsule twice a day. We did the DIM and Detox, 2 twice a day. We did the MRS mushroom formula, which is going to increase the natural killer cell activity, 1 twice a day. And then I also used Cometris Extra Cell. These are frozen live cell extracts from shark and cartilage, the cartilage of shark and horse and pig. They used to be available in Canada. They no longer are, but they're remarkable. They have an anti-angiogenic effect. Because cancer cells have a very specific protein on them, and the immune system, or these cells are able to identify that very specific protein, go over there and cut off all the blood supply to the tumors. And so this is the MRS complex that we know. We have the shiitake mushrooms, we have the reishi mushrooms, again, increased natural killer cell activity. So what we found here was at her 3-month follow-up, her CA15-3 reduced from 72 to 51, and her CA27.29 from 69 to 39. Her 6-month CT scan, there was only 2 existing tumors left, and they'd shrunk by 60%, and there was no new tumor growth. That was the first time she'd ever seen no new tumor growth in over 3 years. Her 1-year follow-up scan, her CA15-3 was 22. That's normal range now. Her CT scan revealed only 2 very small dots, and the biopsy revealed calcification only, nothing active inside of them. 2-year follow-up, all blood levels and CT still remain normal. 8 years later, she's still in good health. So for her, she's not on the extra cell, frozen cell extracts anymore, but because of her genes, she's still on all of the other ones. And she just basically pops in now every now and then to pick up supplements and say hello, but otherwise she's in great health. Without genetics, we could not know this. without looking at the impact of how all of these genes went in together. We couldn't know this. You can't just look at one side of the estrogen. You can't just look at one side of the detoxification. You have to look at it all together. Second case study, this is a 49-year-old female. She was going through perimenopause, and she had difficult time falling asleep, but once she did, she slept right through, and she'd sleep for about 9 hours, but she said she woke exhausted every morning. She thought it was due to the menopause, so she tried HRT, both pharmaceutical and natural, but it didn't have any effect. She used Imivane 3 to 4 nights a week, but she would still wake feeling really tired the next morning. She started craving food all the time. She reported increased hunger, especially in the afternoons and the evenings, and she put on 16 pounds in 5 months despite no change in her diet or exercise. So when we start to look at her genotyping here, we look at CRY1. CRY1 is a gene which produces a protein which blocks our clock genes. We have 2 main clock genes, 1 and 2, 2 being the biggest one here. And the clock genes are what control our circadian rhythm. And CRY1 will also, it blocks the clock gene, but when we're variant, as she was here, it takes a really long time for a person to get from one stage of sleep into the next. It can actually take 3 hours to transition, particularly from stage 3 into stage 4. Stage 4, as we know, being the most important part. So for her, if it takes 3 hours to get from one stage to the next, there's simply not enough hours during the night to get sufficient stage 4 sleep to rejuvenate the body. She's going to wake up exhausted. And that cryptochrome 1, that CRY1 protein that she makes also blocks her clock2 genes, which were also variant. When the clock2 gene is variant, they have increased daytime sleepiness, but they get that revved up feeling at night. So it deregulates all of their circadian rhythms. Here we also looked at her metabolism. So her ADRA-B2 gene, this is about adrenaline, noradrenaline, and cortisol in our fat cells. So the other one that we saw, there's a lot of them to deal with in the lungs that we saw with exercise. This is one that impacts how stress alters our metabolism. And she had increased sympathetic activity, so a slower metabolism here. Her CRCH1 gene, also variant, so she had increased receptors stimulating that HPA axis. Her FTO gene was heterozygote, so a little bit lower adiponectin and leptin and increased ghrelin. So we're going to have a lower metabolism there with increased hunger. And her adipoq gene, coding for the production of adiponectin, also heterozygote. So when I first look at this, I think, well, you know, her metabolic genes are not too bad. FTO and adipoq, they're heterozygote, but they're not variant. The key here is the ADRA gene and the CRCH gene and menopause. When we go into menopause, just as naturally as estrogen and progesterone drop, cortisol rises. And if you remember to the back of the start of the front of the lecture, cortisol impacts over 90% of genes. So that was her trigger. She had a great lifestyle, but she hit menopause. And because her genes, through her genotyping for her stress gene, means increased sympathetic activity, that was enough to produce enough stress hormone to then start turning on her CRY1 gene and her clock gene, which previously had been turned off, and also stimulate her FTO and adipoq genes, which had previously been maintained through a good lifestyle. So again, this often fools people. It certainly fooled me for a long time with patients, why they would do really well for a long period of time. And this explains to us why someone can eat a certain way for a long period of time, and then suddenly it triggers and they start gaining weight. There's always one genetic variable that gets tipped off. That gene gets turned on, and then it starts turning on all of the other genes. So what did we do here? We used Seronetin Plus, 2 capsules in the morning on an empty stomach. So rest reset, 2 capsules 30 minutes before bed. Melatonin time released, 3 milligrams before bed. And that tri-metabolic control, 2 capsules 30 minutes to an hour before lunch and dinner with her. So I'm going to go through these again. Rest reset has that casein decapeptide that Seronetin has in it. So we're going to reset those HPA axis. But it also has passion flower, and passion flower is a really unique herb, as we know, because it increases the production of GABA, but it also increases GABA binding up into the GABA receptor. And that's really key because we can give somebody straight GABA, but it doesn't necessarily mean it's going to get up into the GABA receptor, and particularly the GABA PBR receptor, which is the sedating receptor, and that's what the passion flower will do. This also has the melatonin in it, at the regular melatonin, not the time release. So again, starts to give them regulation of their circadian rhythms. But I also want to give a time-release version of melatonin with this so that we can start triggering that sleep pattern in the middle of the night. And melatonin, again, a huge misnomer with melatonin. It is not a sedative. And the number of times I have patients who come in and they say, oh, I tried melatonin, it didn't work, I didn't sleep. Well, I'm not surprised. If that's the only thing you did, it's not going to work because it's not a sedative. Once we go to sleep, melatonin is responsible for pushing us into stage 4 sleep, that deep sleep. The majority of our stage 4 sleep, it peaks at 2 in the morning. And that's why when people are stressed, they wake at 2 in the morning. Because cortisol's main job is to block melatonin production, increase the inflammation of our receptors that bind the melatonin so it can't bind in there, and thus wake us up at what should be the deepest time of sleep. Because when we're stressed, our body thinks, well, I'm hunting from that saber-toothed tiger. If I go into a deep sleep, I might die. What if the tiger comes? So I'm going to wake you up as soon as you go into delta wave activity. So we need to give a higher dose of melatonin until we start to reset those sleeping patterns. The other thing what we see with melatonin is people getting a lot of nightmares when they take it. And that's, again, if you give melatonin and you push someone into stage 4 sleep, that's absolutely wonderful. The next stage of sleep right after that is REM sleep or dream sleep, which if they go into and you haven't treated the cortisol side of this, they're going to have very vivid, active dreams. And that's why with the rest reset, we put that casein decapeptide in there so it reduces the cortisol, reduces the sympathetic drive. They go into REM sleep and they have the nice, quiet, calm sleeps. Again, another thing to note with the Serotonin Plus or the casein decapeptide that's in Serotonin or the rest reset, although it comes from milk, it's a protein sequence that is only 10 amino acids, whereas the immune system can only identify something that's 12 amino acids or longer. So when a patient takes this, it scoots under the radar, if you will, of the immune system so that they don't have an allergenic or sensitivity reaction to it. And a lot of patients will say, well, is that why they say have a glass of milk before bed and it helps you sleep? It's actually more the magnesium and the calcium in the milk that does it, because saying that you would get this casein tryptic decapeptide by having a glass of milk is like saying, I'm going to increase eggs in my diet, so I'm going to eat cake. Yep, there's egg in there, but we don't eat cake and think, oh, I've got egg. You don't drink milk and think, I have the casein decapeptide. So we have to take it, and that's why we also have to take it on an empty stomach. So getting back to this patient, 4 days later, she was falling asleep very easily, and a week later, her daytime energy began to rise, and that's because she's starting to get into that good stage 4 sleep. And this continued with her for the next 3 weeks. 3 days into her treatment, the food cravings and the hunger started to drop, and that's both a combination of the Serotonin Plus, but moreover that TMC, the trimetabolic control, because it regulates that leptin and that ghrelin, the hunger and satiety hormones. By week 2, she had dropped 7 pounds, and she felt emotionally and physically balanced with food. 10 days into the program, she was sleeping deeply and without fear of falling asleep. And that's a really big thing, because for people who have had difficulties falling asleep, bedtime becomes a really scary time, and that in of itself starts to increase stress as the night progresses. So anything we can do to decrease that is fantastic. Continued her on this protocol for 5 weeks, then we reduced the rest reset to only as needed. So if she was working late or if something stressful happened that day, or even if it was just a random day where she got into bed and the mind started doing this, we just take one of those to quieten the body down. At the 2-month mark, she had dropped 18 pounds, and she went off the TMC. And 3 years later, she had maintained her weight loss, she was sleeping well and feeling healthy. So with this, I didn't even touch her diet. All we can do was play around with her sleep and play around with the hormones that we saw from her genes. So the number of times that we have tried with patients to fix things just with diet and we don't see the results, or we don't see the long-lasting results, we're not looking at the genes. And that's one of the things I really love about genetics, and you'll see with case studies is, again, we can put a patient on a diet, we can put them on a supplement, and we can see a result in 3 months' time, but I want to know what's going to happen 3 years from then. And that's where we get the real great effects with genetics. So the third case study, this is a 39-year-old male. He began working out 2.5 years ago. He runs 30 to 40 minutes a day at a really moderate pace, 4 times a week. With weight training, we do about 8 to 10 repetitions with medium weights, 3 sets, 3 times a week. But he kept getting really frequent injuries. He'd get Achilles tendonitis and plantar fasciitis and tennis elbow, and he would get this every 3 to 5 months, and he would have to stop his workouts for so long that he could never get any progression with his workouts. So he went and had his gait assessed first and found out that he was a heel striker versus a toe striker, and when you're planting for running, you want to put most of the pressure on the front of the foot. He got assessed for orthotics, but he didn't need them. His orthopedic examination revealed a calcaneal encephalopathy. This is a bit of like a bone bruise and a swelling in the calcaneus. That's because he kept planting down on his heel. And the MRI showed beginning stages of an Achilles tear, and the ultrasound on his elbow showed a bit of calcification on the extensor radialis brevis, so the tennis elbow tendon. So the calcification is because there had been so much inflammation there, and as we know, that's what the body does over tendons and joints, is lays down calcium. So he'd done cortisone injections right into the plantar fascia and into the elbow itself. But they weren't very successful, and that's when he came into my office. So looking at his genotyping here, MMP3, this is a gene which talks about the production of a metalloprotease 3 enzyme. This is an enzyme which breaks down collagen, both in the skin and in joints and in tendons. And he was variant for this gene, so he made a lot of this enzyme. Then COL1A1, this is a gene which talks about how well you repair that collagen. And he was heterozygote, so he actually had decreased production of type 1 collagen through this gene, so a little less repair of that collagen. Well, then we looked at the inflammatory cytokines. His TNF-alpha and his interleukin-6 is variant for both of them. So whenever there was an injury or infection or fever or anything in his body, and in this case it's injury, his body's response was to produce a whole bunch of inflammation. And the thing with TNF and IL-6 is that when TNF is increased, it starts to stimulate the production of IL-6 and tip off that gene. When IL-6 is stimulated, it tips off TNF and it becomes a cyclical pattern. And when we have inflammation, particularly in the joints, that gets that MMP3 gene really excited because that's where it's looking to go down and repair and break things all apart. So his TNF and his IL-6 started tipping off his MMP3, and then he couldn't repair things through his COL1A1. Let's also look at the type of exercise that he was designed for. So he is actin 3, he was perfect, he was normal, he was variant. He was designed for longer, slower endurance. His ACE gene was heterozygote, so he needed to moderate a little bit that length of the endurance because he doesn't have as much blood flow across and altered sodium potassium pumps. So what did we do with him? We K-taped him over both of his Achilles and elbows. And K-tape, I don't know if you guys have ever used it, but it's fantastic. When my massage therapist was the first person who told me about it, and at first I was like, really, that's not going to work. And my husband's an orthopedic surgeon, and he goes to her as well, and he had an elbow issue, and she K-taped it, and he came home, he's like, this isn't going to work. It was fantastic, and now he swears, we actually both swear by K-tape. Well, what it really does is it increases the proprioception of the muscles around that joint. So they start to engage faster when you go to step off of it or use that joint. You're going to use your muscles rather than stretching further the tendons and the ligaments. Put some gel heel inserts, just Dr. Sol gel heel inserts to give some extra cushioning on his heels. Use Ligament Restore to help rebuild up, and we'll go through these products, and Resveratrol Extra to help block the cytokine production. We're going to use some curcumin. So curcumin here, for him, it was absolutely fine because his CYP1A2 gene was normal. This is another time where we need to look at integration of genes. So curcumin is a fantastic anti-inflammatory, but it really slows down the CYP1A2 gene, a phase 1 detox gene. And when you're normal is actually in this position is not so good. The Goldilocks position for CYP1A2 is heterozygote. It's not too fast, not too slow. The normal position is too fast. And when we make too many phase 1 substrates, we know when we produce a phase 1 substrate, it always produces a pro-inflammatory, pre-carcinogenic substrate. So we actually want to slow that down a little bit, and curcumin is an amazing way to do that. But if somebody's variant for that gene, you need to really be careful about how much curcumin they're on. I pushed him into water running for 1 month, so he still got the muscle growth and the workouts of running, but without the impact. And ice. Don't ever underestimate the power of ice. There's ice, ice, ice. So Ligament Restore. This is, again, one of my favorite products. It's going to have that BioCell collagen, which is going to bypass through the digestive tract, because we know that they don't all get out, and it actually goes in and starts to repair the ligament. It also helps to decrease the production of those metalloproteases. It also does have anti-inflammatory products in here as well. We have the devil's claw, we've got ginger root, we've got and some more curcumin. So it's an amazing product. One note, if you haven't been using this product, once you've opened it, put it in the fridge. It needs to live in the fridge, just like the glutathione does once you've opened it. Resveratrol Extra, fantastic product for so many things. Yes, we know it is an antioxidant and an anti-inflammatory, but it will actually directly decrease the production of TNF, interleukin-6, and those metalloproteases 3. So with this guy, we could have dropped the production of interleukin-6 as well as TNF with liposomal glutathione and NAC. They're fantastic ways to drop those cytokines. But because we also had the MMP3s, glutathione and NAC won't drop those, but resveratrol will drop them very quickly. So it's sort of less pills with a bigger, better bonus effect there. The optimized curcumin again, and this one with the neurophenol. So this is the Longvita extraction, and for me this is really important. Curcumin has a really difficult time getting from the bowel into the blood, independent of genetics. The Longvita extraction has the best bioavailability, the fastest absorption through the bowel into the blood, so you're going to get a much better anti-inflammatory effect with this. When you're using a non-Longvita extraction, most of that anti-inflammatory effect is going to be in the bowel. So if you actually want to only decrease inflammation in the bowel, actually specifically move to a non-Longvita version, but if I want it everywhere else, I'm going to use the Longvita version. And to be honest with you, there's not really a place that I don't want to drop inflammation all through the body. It's very rarely, it's only in the bowel. So this is, again, going to be a fantastic product to use there. So what did we see here? Well, daily pain and irritation in the Achilles are reduced within days because of the K-tape, again, supporting that joint. 2 weeks into the treatment, he felt as if he could run if he was running for a bus and he wouldn't have any flares afterwards, whereas before, if he sort of jumped off on it, he would get a big flare-up. His elbow pain almost gone by 3 weeks and completely gone by 6 weeks. And that was the combination of the Ligament Restore as well as the resveratrol and the curcumin together for sure. At week 4, had no pain, reintroducing running twice a week, and was back to running 4 to 5 times a week by at the 6-week mark. At this time, we reduced his Ligament Restore, put him on 1 twice a day, and kept all the other supplements the same. Why we keep all the other ones the same for him? One, because he wanted to keep training at this level. So if we look back to his genetics, we remember he was more trained. He was doing about 30 to 40-minute runs, but he's actually more designed for half marathon pace, not the full marathon pace because of his ACE gene with the vasoconstriction, but about a half marathon. So he's actually in the middle distance, not that sort of 40-minute pace. So we're going to we increased the time that he was working out. We slowed it down. And because of everything that he was doing, he did personal bests in his next 7 races. And over the next 2 years, he was injury-free despite working out more than he ever had in his past. Case study 4. This is a 34-year-old female, distance runner in her early 20s. She's very slim. She ate a balanced diet of proteins to carbs to fats, about 25 to 50 to 25 ratio. She dropped out most of her exercise when she graduated university and she started working as a lawyer. She also dropped a lot of her sleep. She was sleeping only 6 hours a night and waking between those witching cortisol hours 2 to 4 in the morning. During this time, she gained 17 pounds in 6 months, no change in diet or exercise at all. She started eating more keto style again, and she began running and training for a half marathon. But during this time, she gained 7 more pounds and felt even more fatigued. So when she came in, we did her genotyping, and her TCF7L2 is normal. She's actually great with carbs from a diabetic point of view. Her IRS1, though, she was heterozygote. So that's, again, the one that stimulates those inflammatory TOR, P13K, IGF pathways, the cancerous pathways. So that makes me want to pull her carbs in just a little bit. Her ApoA2, though, is variant. She's not good with saturated fats at all. She needs to keep them to less than 22 grams per day. And her FTO, this is a different FTO here. She was than the normal, there's a bunch of FTOs. The FTO I showed you at the beginning, a TT would have been normal. This is a different FTO gene. And they have a 2.6-fold increase in weight with saturated fat. So she's got 2 genes here. She's variant 4, not designed for saturated fats, but she's actually not too bad from a weight point of view with carbohydrates. When I look at her exercise, though, her Askin-3, she's normal here, so she's actually better with sprinting. Her ACE is heterozygote, though, so we need to moderate those sprints a little bit. And her ADRA-V2 is normal, so she's, again, designed for short bursts of oxygenation to those muscles, not the endurance that she started training for. So what do? We basically returned her almost to her original diet. So more healthy carbohydrates at each meal, about 2/3 the size of the protein. When I say the healthy carbs, those again are the grains and starches, the sweets and the fruits, but using more of the whole grains. Vegetables, salads, they're unlimited. They don't count here. Reduced her saturated fats to less than 22 grams per day. So just to put that in perspective, somebody who is doing, say, a bulletproof or keto diet, 1 ounce of coconut oil is 17 grams of saturated fat. 1 tablespoon of butter or ghee is 7.8. So that bulletproof coffee in the morning puts you over that 22 grams of saturated fat per day. Through that ApoA2 gene, that, as we saw at the start, that stimulates ghrelin. Ghrelin increases hunger, but it also increases the desire and food cravings all day long, and it increases adipogenesis through both her FTO and her ApoA2 gene, which means anything that she eats for the rest of the day, she's going to start storing as fat because of that little bulletproof coffee first thing in the morning. So we need to drop her way down. And to drop below 22 grams per day, most people think, oh my God, how can I do that? If you pull out coconut oil, it's pretty easy to do, or MCT oil, it's identical. If you switch to more almonds and walnuts versus cashews, macadamia nuts, then you can still keep some of the meats and the chickens and all of those in, because it's pretty difficult to get above 22 grams of saturated fat if you pulled out all of the bulletproof keto products that are now on the market. Then we also want to maintain her protein at about 0.7 grams of protein because of her FDO content per kilogram divided into 3. So we actually lowered her protein a little bit. We changed her to a modified HIIT. So again, she had that muscle fiber for HIIT with a little bit decreased blood flow. So 80% efficacy with her sprints, with a 30 to 40% recovery. So in the other case study, it wasn't quite as fast as this. So you can see how our genes really dictate how fast those sprints are going to be, how long they're going to be. The big thing, though, that happened here was she graduated school, she started in a law firm, and her stress went through the roof. So stress, again, as we saw, tips off all of those genes. That's what then started to tip off her exercise genes, her ApoA2 and her FTO. So we've got to fix that causal factor again. So we used the Serenitrin Plus 2 twice a day. We did 1 dose an hour before bed and 1 capsule if she waked in the middle of the night. because that's when we want to start to retrain that cortisol peaking in the middle of the night. We used, again, melatonin time-released here. I'm going to use 6 milligrams 1 hour before bed. In an ideal world, you would use the melatonin around 8 p.m. That's when naturally our bodies start to release melatonin so that it peaks at 2. And again, it's not a sedative, so if you take it at 8, doesn't mean that you're going to be asleep by 8:30, but that's its natural rhythm. Regardless if you are going to get into bed much, much later than that, try to at least take it an hour before bed or have your patient do that. So she lost 2 pounds in the first week, and she felt a lot less muscle fatigue. She was sleeping through the night within 10 days. She was more rested on waking. At 8 weeks, she had lost 19 pounds, and by the end of the 3rd month, she had lost almost 28 pounds, so more than she had even gained at this time. 2 years later, she was spending less time working out because now she's doing what she was designed for, the more HIIT and shorter workouts, not the endurance ones. She was eating more food than she ever had before she was gaining weight, but she was keeping all that weight off, and she had great energy, and she was sleeping consistently. So again, if we took a look at this, we may not have changed her back from keto. We may have said, no, keep going towards longer endurance if that's what you're, enjoying doing right now, or if you're going to be burning fat, quote, burning fat for a longer period of time. Our genes really dictate everything that we do. So putting all of this together, genetic testing it's growing exponentially. So I say hats off to all of you who are listening to this because our patients are crying out for it. And if we don't learn it, they're going to go to somebody else who is going to take control of that, because it truly is personalized medicine. There is no cookie cutter formula for anything anymore. And it really helps us see what areas that we need to zone in on for their health so that we can start to get more effective preventative intervention mechanisms here. And it's something that, it's near and dear to my heart for sure. It actually literally saved my life. But for all of those patients that are walking through your door and you're scratching your head and you're thinking, why is it not responding the way that it should? Or it's a referral from a medical doctor and they're like, I don't know what to do, I've tried everything. This is where we can delve deeper into it. The beauty of what we can do as healthcare practitioners, and this is what I'll always say to my patients with genetics, is we're only looking at genes that are actionable. So I will never hand a patient a death sentence, if you will, with those genes, a gene that I can't do something about. I don't even want to know about that gene. I want to know about the genes that turn on that gene. And the perfect example of that is the BRCA gene. So many people are positive for it, and then they're just stressed for the rest of their life. But if they code really well for CYP1A1 and 1B1, they don't really need to worry about it. I'm not saying let's be reckless, but they don't need to worry about it at that level. Or I see so many patients who have a family history and they almost pre-program that disease coming out because that's all they're thinking about. Well, let's find out what's going on, what you actually inherited from your parents, and then how we can turn things off. Because all of the genes, everything that we do as natural healthcare practitioners is stimulating the innate healing response within the body. That's the first thing we learn when we get into school. That's what genetics is. It is our innate healing response. We just need to know what it is for us individually, and then we know all the tools. People get really scared to use genetics. They think it's this really big field, but if you just sit back and think about it, you know what 4-hydroxyestrogen does in the body. You know what adiponectin or leptin does in the body. We know how to drop tumor necrosis factor. So we have to sort of step back, just look at the name of the gene, look at what it does, and say, okay, that means increased inflammation. What do I do for inflammation? This is what I do. And then we start to look at it as it starts to impact the body. And that's the other thing that we are taught as natural healthcare practitioners is integrate everything in the body. Don't look at each system separately. Look at it as a whole, because one thing is always going to affect the other. And when we look at genetics, we can really key in on how increasing one thing is going to affect another. And again, that CYP1A2 with curcumin is a really great example of that, because if we give somebody who's variant curcumin and it starts to increase their inflammation, That then can tip off interleukin-6. Interleukin-6 can then tip off, everything. Inflammation can start to tick off the metalloproteases or the collagenases or the FTOs. Inflammation can tip off so much. So we really have to pinpoint down what is going on in the body and then take a step back, as our education tells us, and look at how we would repeat that. And look at the patient in front of you. Again, just because we have that gene doesn't mean we're expressing it. So somebody may code for low serotonin or low dopamine. I'm a perfect example. I code really low for dopamine. If I don't exercise, I would want to eat almond, I would eat cheese and nuts and wine, the dopamine foods, all day long. But I exercise every day, and that keeps my dopamine high, so I don't need to go into a dopamine treatment. So start to, again, marry the genes with the patient. Don't just go straight into treating them. And another thing they see with docs always asking is, where do we start with it? And the best place to start is whatever that patient is walking through the door. You may see SNPs come up in a bunch of different categories, but start first, even though you know that their detoxification pathways are horrific and they need it, and that might be your primary goal because it affects so many other things. If they're walking through first and they want to lose weight, target that first. Get them feeling better with that first, and then start to go into the other arenas within the genetics for them. Because I would say probably about 60% of my patients want to target everything at first, but that's because I've done a lot of education with them. There's a lot of people who just want to do one area at a time, and they'll get too overwhelmed with too much. So start slowly. Start with what they're walking through your door with. If you want the real lowdown, well, all you need to do is get some of your DNA. We don't need to start guessing these games anymore. So again, as we spoke about upcoming lectures that are coming, complimentary webinar series, we have the UNDA series, and this is going to be a series of 7-session webinars. And again, you will get emailed information about all of these that are coming up, as well as we have an evening and day events with Nigel Plummer and Sam Yannick. I don't know if you've ever heard either of these speakers. They're both absolutely outstanding, so I would certainly encourage you to either listen in on these or attend these days because they're absolutely outstanding. So again, just a reminder, there's a 15% off on all products that are included in this presentation, and you need to use the promo code, PKR 2020. But it's only valid in Canada until February 26th. And I think Fatima said that if you are listening in from the U.S., then if you just call into your rep, they will give you instructions as to how you can get a discount through them. So I know I've left sort of 25 minutes here for questions, but usually this is a topic which generates a lot, so I welcome any questions.
Thank you, Dr. Reed. We are going to take some participant questions from the Q&A panel. The first participant question is, do you have a go-to company for genetic testing?
So in terms of testing the raw data itself, I use 23andMe with my patients. So there's two things. In Ontario, as naturopaths, we're actually not allowed to requisition genetics. We can interpret genetics, but we're not allowed to requisition it. On the West Coast, they are. But the reason, even if I was, I would still use 23andMe because it gives the widest variety of gene testing for the most economical price. Genetics is expensive, and not everybody can afford that, and certainly the treatment is also expensive. So I want to be able to offer it at a better price for people. When there are companies that do the whole genome, it's very expensive, but there's no point. Again, 1.2% of our genes are the actionable genes that are clinically relevant. The rest of them right now are clinically irrelevant. People have a big concern about the privacy with 23andMe, and I certainly understand that. These days, though, you can pretty much hack anything you want. There's any website almost can be hacked. But what I do encourage patients to do when they're ordering their kit is just use a fake name. You can use any name you want when you are purchasing or ordering that kit, and then there's no trace back. As a practitioner, you just have to keep track of that, obviously, but that is something that our boards also allow. But the other important thing with 23andMe is you need to do the health and ancestry, not just the ancestry, because the health and ancestry is the one that has all the health genes. And they go on about 50% off on almost every holiday. The next one being Valentine's, but it's Father's Day, Mother's Day, Thanksgiving, Christmas, New Year's, you name it. They always go on sale. So again, it makes it a lot more economical. I used to use a lot of private companies that were about 3 times the price, and it became very prohibitive. They also didn't have all of the genes that I wanted to test in patients, so that's the one that I use.
Thank you. The next question is, can you recommend a resource for practitioners to access that shows the different genes and their associated biological expressions? Absolutely.
So I'm actually just finishing a book on that right now. This will be a book I will carry in my office as opposed to my other 5. It's very difficult. At present, there is not a great summary of them. The platform that I designed, GeneRx.ca, if you go onto it and you look at a sample report there, you will see it explains in huge detail what each gene does, what the key variant points are for that gene, what are the alleles for that gene, and it integrates everything in together, and it also gives an editable report. So a doctor can actually edit it and change supplements to a different company or a different brand or a different supplement that they would like. But on there has basically what I wanted if someone had handed me that 12 years ago when I started in genetics. So what I've done here is taken every different website on a single gene that I could find. When I found a common trait for that gene on 7 or more websites, then I would say, okay, I trust that trait. Then I would go back and find the clinical studies behind it, back that up, and then I would say that's a keynote symptom for that gene and carry on to the next one, the next one, and the next one. So that's the only place right now that I know has all of that information for a wide variety of genes. You can do, like Dirty Genes has a lot of different genes, but they're mostly detoxification and methylation genes. There isn't a book at present right now that has a wide variety of genes that are very specific, most of them being detox and methylation. But if you just whip onto the site, you don't need to upload anything, you don't need to start an account, you can just take a peek at a sample report, and that gives you an idea of the type of information. And a lot of the docs who use it say that's actually where they've learned most of their genetics from.
Thank you. The next question is, does the Pure Genomics report provide recommendations on the type of physical activity to do based on your SNP?
So it doesn't use all of the SNPs that I do. It has a lot of wonderful, wonderful SNPs, but it doesn't use all of the SNPs that I use. And the bigger part is it doesn't integrate them. So for the actin-3 gene, for instance, which absolutely it has, it would say you're either a sprinter or an endurance runner. But then it would marry with it the ACE gene or the ADRA gene in terms of do you provide oxygen or blood to it and moderate it. It's still a report that does gene by gene treatment. But for each of those genes, it has a wonderful treatment protocol.
Thank you. The next participant question is, what happens if you have 2 opposite codings for 2 different genes in the same health category? For example, you are homozygote normal for one phase 2 detox gene and homozygote variant for another. Does one
really
cancel the other out?
Yeah, really great question. And no, they don't cancel each other out. They will moderate each other, but whenever I see, particularly for detoxification, if I see one variant gene, I'm going to treat that one gene. It's just I don't treat it as aggressively. So if I was to use, say, 2 capsules BID for a variant gene, and then the other one is normal, I might drop it to 1 twice a day. But there is not one duplicate of a phase 2 gene. So if you go into a GeneRx report, you'll see on each of the phase 2 detoxification genes, yeah, they're phase 2 genes, but they actually all clear out different substrates. They clear out different toxins, they clear out different types of hormones, they clear out different types of medications. So you also have to look at that as well. So even though they're normal for one, you're going to get different substrates that aren't being cleared in that variant one. So whenever I see two opposing genes, a variant and a normal in the same category, I still treat them. I just moderate the treatment. Kind of like the sprinting, but they don't have the blood perfusion. I'm still going to have them do intervals, but I'm going to make them longer, slower intervals. Kind of like that philosophy.
Thank you. The next participant question is, how do you know if you are expressing a gene, and thus how do you know if you need to treat it?
Very good question. Sometimes it's really easy, weight gain, or we could see aberrant folic acid levels or B12 levels in the blood. But a lot of the times it is really difficult to know, and then it becomes a guessing game. So if I'm unsure and it's a gene like a detoxification gene, I'm always going to treat it because it's such an important gene. Most often, if it's an older person, so again, towards perimenopause, they're going to start expressing it at some point. But the ones that really are easy to see are the hormones. So somebody may code poorly for dopamine or serotonin, but they have a very balanced lifestyle, just like I mentioned myself with running. So I don't express low dopamine symptoms unless I'm injured and I can't run, then I will. Similarly, if somebody has poor stress gene responses, but they don't have anxiety, they don't have sleep issues, again, you might not need to treat it. But when it comes down to an inflammatory, well, even inflammatory, they don't have any inflammatory conditions on them, I probably would still treat it, but at a really mild level, or I would treat it through the detoxification genes. But a lot of the times, it's actually given me the answer. So the number of times I see patients with high vitamin B12 in their blood, and a lot of people probably see this too. They're like, I'm not even taking B12. And then I think, this is great, look at me, I must be eating a lot of B12. And I'm kind of like, well, not so much actually. When I look at your genes, their MTHFR genes with the methylfolate are not functioning well. And you need the methylfolate to take the B12 out of the blood and put it into the receptor. And then they also don't have very many B12 receptors. So a lot of that B12 is getting stuck in the blood. So again, once you start to learn the ins and outs of genetics, you could look at their B12 levels and start to guess things there. But the biggest answer with that is just looking at your patient, look at what that gene does. And if you can figure out like a hormone depression or inflammation, etc., if you can't figure it out, I would probably treat it at least for 8 weeks. It takes 8 weeks to push a gene into its optimal position. If it's already optimal and we treat it anyways, that's going to be okay. I would just rather put it in that optimal position and then pull away that supplement.
Thank you. The next participant question, and the last participant question, is how do you know where to begin treatment if a patient has SNPs in many different health categories?
Absolutely. So as mentioned, what I usually do is I explain to my patients how, again, the integration of genes and why treating only one category to start with is not the most ideal. However, the very first thing I will make sure that I treat when I do their genetics with them is whatever they walk through the door, whatever brought them through the door. So if their chief complaint is weight gain, I'm definitely going to go to the metabolic and dietary panels, and I'm going to treat those first. And that's overwhelming. You know, when you suddenly hand a patient a bunch of supplements and a whole bunch of dietary changes, that's a lot. So I'm going to start with just what they walk through. I'll just use the metabolic supplements, just use the diet section. And then once they start to get a handle on that, or after 8 weeks when supplements usually reduces the dosage in half because we've already flipped that gene, then I'll move into the next category. If it's for a family history reason, then whatever that disease is, I'm going to go straight to that area. If it's cardiovascular, if it's immunity, if it's cancers, etc., I'm going to go to all the genes that deal with that and then start treating those first. But it's really a conversation that you have with your patients. And some of them, as I mentioned before, some of them will really want to start looking at all of them at once, and some of them only want to treat one area to begin with.
Thank you. Thank you, Dr. Reed. That was the last question for this evening, and I want to thank you so much for an excellent webinar, and thank you everyone for joining us this evening. If there are any questions remaining, please feel free to contact your Atrium Innovations representative. Also, don't forget to take advantage of the PKR 2020 promo code for all products included in this presentation tonight. The promo code will be valid until February 26th. And also please note that the promo code is valid only for Canadian clients. The U.S. clients are encouraged to call the toll-free number for special promotion. Please note that also a recording of this webinar will be available on the Soroil website beginning next Wednesday, January 29th until February 26th. Everyone registered for this evening's event can also expect to receive an email with instructions on how to access the recording. And also please be aware that our medical advisors are on staff and available to support you. If you do not have an account with us and wish to do so, or if you have any follow-up questions, you can contact us at 1-800-263-5861 if you're in Canada, or 888-737-6925 in the U.S. Thank you once again and enjoy the rest of your evening.
Thank you so much.
Thank you. Ladies and gentlemen, your conference has now ended. All callers are asked to hang up their lines at this time, and thank you for joining today's call.